he discovered the connection between gallstones and pancreatitis. He is the one who originated the common channel hypothesis. This was based on autopsy of patients with hemorrhagic pancreatitis, where he found that these people had a stone in the common bile duct, dilated pancreatic duct, and common bile duct. And he hypothesized that there is a backflow of bile into the pancreatic duct producing pancreatitis. But we know now that this is regarded as a myth because anastomosis of bile duct to pancreatic duct in animals did not cause pancreatitis. Fitzgerald sarcastically said, never in medical history have so many owed so much to a single stone. Yeah, Colley is another important person who actually the first person to bring the link between alcohol and pancreatic disease. He described a 34-year-old man who was accustomed to free living, strong corporeal exertions in the pursuit of country amusements, basically an alcoholic who died of diabetes and emaciation. At necropsies, pancreas was studied with calculi. Incidentally, Colley is also the one who made the connection between diabetes and chronic pancreatitis. Friedrich coined the term drunkard's pancreas. There are many, many people who have had their names associated with various etiological conditions and pancreatitis. There is a long list. Speck, hyperlipidemia and pancreatitis, John Shea, Ascaris and pancreatitis. Of course, we have Kuru, who later on went to describe this from the Kashmir Valley. Harris, infectious pancreatitis, first guy who said mumps can cause pancreatitis. Dawson and Struthers, hyperparathyroidism and pancreatitis. Comfort and Steenberg from the Mayo Clinic. I think Steenberg is from, at that time, from, I'm not sure, Mayo Clinic or Harvard. Hereditary pancreatitis. Zion, steroid-induced pancreatitis, and we know that many other drugs can produce pancreatitis. Gosset, surgical papillotomy and pancreatitis. Now we know that endoscopic papillotomy also produces pancreatitis. Waterman, spider bite and pancreatitis. Gregg, pancreas divisum and pancreatitis. And McKay, the first one who said there could be a connection between autoimmune disease and pancreatitis. And of course, the genetic revolution, and we have Whitcomb. You know that he's the one who first made this discovery. Hereditary pancreatitis is caused by a mutation in the cationic trypsinogen gene. And in 1998, two others, same time, Scherer and workers, and Kohn and workers, said cystic fibrosis gene mutations, there is a connection between that and idiopathic pancreatitis. We go on to the biochemical diagnosis. Julius Wohlgemuth from Berlin is the first one who showed a method to determine serum amylase, but Robert Ellman from St. Louis, USA showed that there was a connection between pancreatitis and elevated amylase. Cherry and Crandall, another famous biochemist, first one who showed the method how to determine serum lipase, and Comfort from the Mayo Clinic showed that there was a correlation between pancreatitis and elevated lipase. When you look at disease severity, it's actually two names that come into mind. One is John Ranson of the New York University Medical Center, who first came out with the criteria for severity of acute pancreatitis. That was followed by many others because it was not an ideal system: Glasgow, Apache, Marshall, SOFA, etc. An important point is the Atlanta classification, where organ failure as a central determinant of severity was brought in. Balthazar was actually John Ranson's colleague at the same college, and he has given us the radiological grading of severity. And even 25 or more years later, we don't have a better imaging description of severity of pancreatitis. We finally go on to management. I think before that we need to remember Nicholas Sen. He was a Swedish man who came into the US and studied at Chicago Medical School. And again, he went back to Europe and worked with anatomists, surgeons, pathologists. And he is called the father of experimental pancreatology, provided many guiding principles for pancreatic surgery. We come in more recently. this is something that Irwin Maudlin has said. Surgical management is a chronicle of confusion and despair, with alternative waves of enthusiasm for surgery or conventional management. Up to the 1920s, surgery was practically recommended in all cases by Sen, Corti, Moynihan. At that time, Fitz, as we saw earlier, and Mikulicz said that conservative treatment was better. From 1930 to 70, conservative management ruled the roost because surgery had a very high mortality of close to 80%. And it is said at that time a 10-minute surgical discussion of acute pancreatitis would probably include 9 minutes of silence because there was no surgical management plan. 80 to date is a balanced approach, and we see important people here. Hans Beger from Ulm, Howard and Bradley, who have contributed by a lot of seminal work in pancreatitis, necrotic versus sterile necrosis, infected necrosis, open drainage, closed drainage. They have contributed a lot to the field, surgical management of acute pancreatitis. Nowadays, it has moved from close to minimally invasive techniques, laparoscopic, endoscopic, percutaneous approaches. When you look at endoscopic approach, Todd Barron, now working at the Mayo Clinic, is the founder, who endoscopically was able to do necrosectomies and improve the problem. These two gentlemen should be remembered. Kawai from Osaka and Meinhard Klassen from Germany, who at the same year, 1978, performed endoscopic papillotomy and removal of CVD stones. And this was the era of an alternative treatment for gallstones other than surgery, which is an endoscopic removal. Safrani and Cotton advocated emergency papillotomy, and we have a series of studies that came after that, Neoptolemus, Fan, German study, which have now given us proper guidelines how to endoscopically manage gallstone pancreatitis. What about medical management? Not any better. There are continuing controversies and limited options. Interesting, many years ago, Bigsby, that was the time of the bloodletting, he advocated limited bleeding by putting a dozen leeches to the anterior abdominal wall. When you look at pharmacological therapies, we have a whole range of therapies that have been attempted, but it is a litany of failed trials. The area where major advances in medical therapy have been are actually supportive therapies, nutritional support, intensive care, management of shock and organ failure. So in conclusion, Chairman and friends, most of our knowledge of pancreatitis actually comes from shadows cast by the disease. We really don't know yet what really goes on in the pancreas. We do not know the sequence of events that lead to initiation and propagation of enzyme release. We still are not very clear about the pathogenic mechanisms that underlie certain etiologies like alcohol and gallstones, because all people who drink do not get pancreatitis, all people with gallstones do not get pancreatitis. And after 4 centuries of inquiry, the most effective interventions are purely supportive and not specific to the pancreas. However, there is hope for the future. New techniques offer hope for the future, and I believe that we have to understand the present and to plan for the future. We really need to know the past, and I hope this has been helpful to you. Thank you very much.
That was a wonderful disposition of historical perspective, Professor Ashok, as usual. Thanks for the beautiful slides and an entire cover of the history. Do we have time for questions, Professor Raghunathan? I think we can. 1 or 2 questions, sure, if there are any. I think I'll initiate. Professor Ashok,
I'm sorry to interfere, sir. I think in state of art lectures, we do not entertain questions, sir.
Okay. Thank you.
Yes,
thank you.
Yes, sir.
Thank you, sir. Thank you.
I now request Dr. Ashok Chako to give away the mementos to the panelists. We'll now break for tea for about 5 minutes.